Okay, welcome everybody. This is Chapter 6, and what we're going to be dealing with here are musculoskeletal system diseases and disorders. Now, if we look at the skeletal system, we find that it's divided into two divisions, the axial and the appendicular. Um, what are the functions of the skeletal system? Well, it's to provide structure, a framework for the soft tissues of the body. It also provides movement. It serves as a storehouse of minerals, calcium, iodine, phosphorus, hydroxyapatite just being a few of the minerals that are stored in the skeleton. And it's also a major site of blood production, hematopoiesis, which takes place in the bone marrow. Um, the skeleton is what we would call in biology an endoskeleton, meaning that the hard parts are on the inside. As a result, as the skeletal system increases in size, the soft parts can form around it, and the entire set of body dimensions will tend to increase. This is different from organisms that actually have their hard parts on the outside. Those are called exoskeletons, and so there's a logistic problem when those organisms are growing. They have to shed their smaller exoskeleton, and for a period of time in their life cycle, they'll actually have a soft outer covering. While the soft parts grow, eventually what happens is that the exoskeleton will reharden. This is an act called molting. We get to avoid this because our hard parts are on the inside. Now, an interesting thing about the skeleton is that it's actually formed from cartilaginous tissue during development. We start out with a skeleton that's made up entirely of cartilage, and as we develop in the mother's womb, that cartilage is eventually replaced with ossified tissue. By the time we're born, the only remnants of the cartilage model of the skeletal system are found in the joints, where we see it as articular cartilage, and at the ends of long bones as a structure called an epiphyseal plate. And as long as the epiphyseal plate persists postnatally, the long bones of the skeleton are capable of growing in a longitudinal direction. After they seal, eventually what happens is that the only possible bone growth is in the widthwise or appositional direction. You can see the major bones of the skeleton here. We reviewed these at some length, but we can go through them briefly. The skull is made up of the cranium and the facial bones. The cranium anteriorly is formed by the frontal bone, posterior laterally the parietal and temporal bones, and then at the back the occipital. And the facial bones are primarily composed of the zygomatic bone, the cheek, the nasal bone, the bridge of the nose, the mandible, and the maxilla, the lower and upper jaws respectively. And then the internal bones, the inferior nasal conchae, the lacrimal bones, which are on the medial aspect of the orbit, the ethmoid bone, which is behind the nasal bone, forms the upper part of the nasal cavity and part of the nasal septum, and the vomer, and then finally the sphenoid bone, which is unique because it articulates with every other bone in the cranium, so it's, as it's nicknamed, the keystone of the cranium. Below the skull, and we should also mention the hyoid bone, which is just below the mandible. It does not articulate with any other bone in the body, and the auditory ossicles, which are found in the middle ear. Below the skull, we have the vertebral column made up of vertebra. There's three divisions in the vertebral column: the cervical, the thoracic, and the lumbar division. 7 vertebrae in the cervical division, 12 in the thoracic, and 5 in the lumbar. And then we end down here at this structure, the sacrum, which is basically 5 fused vertebrae, and then the tailbone or coccyx, which is at the inferior aspect of the sacrum. This articulates with the os coxa laterally. There's 2 os coxa, one on the left here and one on the right. They meet anteriorly at the pubic symphysis, and they articulate posteriorly with the sacrum. The os coxa articulates laterally with the femur, the longest and strongest bone in the body, which articulates distally with the tibia, your medial strut of your lower leg. The tibia articulates laterally with the fibula, and the patella articulates posteriorly with both the tibia and the femur. Heading back up to the pectoral girdle here, your collarbone, known as your clavicle, articulates posteriorly with your scapula or shoulder blade. Um, the midline of the rib cage is formed by the sternum, which has three regions: the manubrium, the body, and the xiphoid process. And the glenoid fossa of the scapula articulates laterally with the humerus, the long bone of the upper arm, and the humerus articulates distally with the radius on the thumb side of the upper arm and the ulna on the medial side of the forearm, rather. And these articulate distally with the carpals, the bones of the wrist, which articulate with the metacarpals, the bones of the palms of the hand, which articulate with the phalanges, the bones of the fingers, also incidentally the names for the bones of the toes. Let's finish up the lower extremities. The tibia articulates distally with the talus, and the talus articulates with the calcaneus, your heel bone. The calcaneus and the talus articulate with the metatarsals, the bones of the sole of your foot, and these articulate with the phalanges and the toes. Okay, so that's the skeletal system in a nutshell. There's different kinds of joints in the skeletal system. Freely movable joints are characterized by a joint cavity which contains synovial fluid and a high degree of range of motion, or ROM. Examples of these diarthroses include the knee joint, the hip joint, the shoulder and elbow joint, the joints between the fingers, and the shoulder joint. There are also slightly movable joints, characterized primarily by the presence of cartilage in the joint cavity, examples being the pubic symphysis, the sternoclavicular joint, the joints between the ribs and the sternum, and the joints between the vertebrae, okay, just to name a few. These are called amphiarthroses, slightly movable joints. And then we've got immovable joints, which are characterized by a tight seal between bones that is not capable of any degree of movement, and these are characterized primarily by gomphoses between the teeth and the jaws, and sutures that you find between the flat bones of the skull, and also in bones such as you can see the sutures sometimes in the form of sutural bones that are little advantageous pieces of flat bone that occur between suture lines that are a feature of some individual skeletal system. Okay, bones can be divided into types. Long bones are longer than they are wide or thick. Examples include the humerus of the upper arm. Short bones have small dimensions. Examples of these are the carpals and the tarsals. Flat bones, they're not perfectly flat, but they are flatter than they are anything else. Examples of flat bones would be the scapula, the flat bones of the skull, such as the occipital and frontal bones. And then there's sesamoid bones, which have unusual shapes. Examples of these would include the kneecap. The long bones tend to be found in the upper and lower arm and upper and lower legs and the fingers and toes. Examples of sesamoid bones include the patella. There are also irregular bones. Examples of these would be bones such as the vertebra, have unusual shapes. Now, the skeletal system forms joints, as we just previously discussed. Another name for a joint is an arthrosis. Movable and immovable joints differ in their range of motion. Movable joints are capable of some type of movement, slight movements in the case of an amphiarthrosis, and a greater range of motion in the case of a diarthrosis, which normally features a joint capsule, synovial fluid, bursa, ligaments, tendons, and immovable joints are distinct from either of these. They're made up of interlocking bone and are incapable of movement. Examples include sutures, such as you find in the flat bones of the skull. Three types of material that are found between bones include cartilage, synovial fluid, and the joint capsule proper. And here you can see examples of these different types of joints. Okay, here is a diarthrosis, okay, freely movable joint. In fact, the shoulder is the most freely movable joint in the body, and as a result, it's the most frequently injured, and you'll find that that's generally the case. The greater the range of motion, the greater the potential for injury. Here's a synarthrosis, a suture between the flat bones of the skull. Here is another example of a diarthrotic joint, the elbow joint, which is a hinge joint. Amphiarthrotic joint here, the joints between the vertebrae. You can see the intervertebral discs, which are basically cartilage that are capable of a slight degree of movement. Same is true with the pubic symphysis, another amphiarthrotic joint. And then down here, the joint between the radius and ulna and the carpals. This is the wrist joint. This is also a diarthrotic joint. It is freely movable. If we look at skeletal tissue proper, there are other accessory structures that we need to take note of. Ligaments are tough, dense, fibrous bands of connective tissue that hold bones together. Tendons are strong, tough cords of dense connective tissue that attach muscle to bone. And cartilage is semi-smooth, dense, supporting connective tissue. There are also accessory structures that help to lubricate the tendons. Bursae are closed sacs or cavities of synovial fluid that are lined with synovial membrane. Very often they can cover aspects of the joint, or sometimes they're actually present as tendon sheaths that allow easy sliding of tendons over structures such as muscle and bone in order to ease movement. The synovial membrane that produces synovial fluid, this is sort of like a biological oil that eases the range of motion in these joints. The fascia is connective tissue that covers, separates, and supports the muscle. An injury to a tendon is called a strain, and cartilage, as we already discussed, is primarily found at the ends of bones within freely movable joints or in the epiphyseal plates. You can also find it in the intervertebral discs at the tip of the nose and the outer aspect of the ear or pinna. Okay, some common signs and symptoms of bone and joint disease include pain, swelling, decreased mobility, and deformity, and muscle disorders are often characterized by weakness. Some diagnostic tests that we can perform include X-rays, which allows us to visualize dense tissue without actually having to open you up and look at it. CAT scans, magnetic resonance imaging, and blood studies, including calcium and phosphorus levels, electromyography, and muscle tissue biopsy, where we actually take a sample of the tissue and look at it under a microscope to see any abnormalities in shape or changes in function. Okay, bone diseases can be mild to severe, and they're common as adults age. One of the areas of the skeletal system that is often affected by bone disease include the spine. So, lordosis is an exaggerated inward curvature of the spine. This is basically an extreme lumbar curvature where we thrust the abdomen outward. We see this very often in pregnancy and in obesity. Kyphosis, also known as hunchback, is an abnormal outward curvature of the spine and is often exacerbated by conditions such as osteoporosis. And scoliosis, also known as swayback, is a lateral curvature of the spine. Some of the possible causes of lordosis, again, obesity and pregnancy. Scheuermann's disease is a degenerative deformity of the thoracic vertebra that can result in kyphosis. Again, most probable cause of kyphosis in older persons and postmenopausal women is osteoporosis. The reason for this is the lack of estrogen. It leads to a thinning of the bone, and because the weight is disproportionately on the anterior aspect, the spine will tend to slump forward. The age and gender group most likely to develop scoliosis is teenage women. So let's take a look at major spinal disorders.
Good. Curvatures have a downside, namely curvature abnormalities.
Curvature abnormalities can be blamed on any number of factors. Some are congenital, which means they were present before birth. Some are even caused by bad posture. There are few common curvature abnormalities, like scoliosis, kyphosis, and lordosis.
Scoliosis, for instance, is an abnormal curvature that usually occurs in the thoracic region of the spine. That's the second region that forms the upper backbone. For some unknown reason, scoliosis is more common in girls and can sometimes be caused by having lower limbs of unequal length. Scoliosis can sometimes be treated surgically or with a body brace. Kyphosis is an extreme thoracic curvature, creating a condition known as hunchback and inspiring lackluster animated films. You can get this disease from rickets and tuberculosis of the spine. Lordosis is an extreme lumbar curvature and is commonly referred to as swayback. Lordosis sometimes affects pregnant women and individuals with potbellies. This is because people with potbellies have a tendency to thrust their abdomens forward.
Okay, so what are some of the treatment options for lordosis? Well, weight loss, exercises to strengthen abdominal muscles, and pelvic tilt exercises can all aid in correcting this lumbar thrust. For kyphosis, we can use exercises to strengthen muscles and ligaments, a back brace to stabilize the condition, and in severe cases, spinal fusion, which is where we actually make two vertebrae become a single unit. We can also use temporary immobilization to correct the condition, and vertebroplasty. Spinal fusion is also known as spondyloses or spondylocendesis. This is a surgical technique that is used to join two or more vertebrae together. Often we use supplementary bone tissue, either from the patient as an autograft or from a donor as an allograft, in conjunction with the body's natural bone growth. Osteoblastic tissue then helps to fuse the vertebrae. The osteoblasts, remember, are the bone builders, the osteoclasts are the bone dissolvers, and the osteocytes are the osteoblasts that actually get trapped inside the lamellae of compact and spongy bone. Vertebroplasty stabilizes collapsed vertebrae using specially formed acrylic bone cement, and it's typically an outpatient procedure. There's no hospitalization or surgery required, and it requires only a local anesthetic. For scoliosis, we can use exercise to strengthen weak muscles, the use of a back brace, or fusion of the vertebrae. This is also, while we're on the topic, scoliosis is generally diagnosed in high school. The earlier this condition is recognized, the more successfully it can be treated. Osteoporosis is a condition characterized by loss of normal bone mass and density due to imbalances between the breakdown of old bone and the manufacturing of new bone. Osteoporosis is considered a metabolic bone disease because it can originate from hormonal or dietary factors as well as disuse. Some possible causes of osteoporosis include radiation treatment, malabsorption of calcium, smoking, immobility, chronic diseases such as rheumatoid arthritis, senile and postmenopausal osteoporosis usually results from a lack of estrogen. Osteoporosis can also result from the use of medications such as heparin, phenytoin, and cortisone meds, as well as prednisone and prednisolone. The bottom line is that often this is asymptomatic until we see a bone break. This is what we call a pathologic fracture. Spontaneous fracture and loss of height are the most common signs. The treatment includes an increased intake of calcium and vitamin D, estrogen replacement therapy for postmenopausal cases, biphosphonate meds, and moderate exercise. Examples of biphosphonate meds would be medications such as Fosamax. So here's a look at osteoporosis.
Osteoporosis is a degenerative disorder of the skeletal system. It is a syndrome which occurs most frequently in women over 45 years of age. In osteoporosis, there is a general thinning of bone density with weakening and loss of bone. There are no chemical changes in the bone, simply less bone. More prevalent in women, it is estimated that at least 25% of all women will be affected. Osteoporosis occurs when new bone formation remains constant, while the degree of bone breakdown increases. Bone mass becomes thinner and porous. Contributing factors include a sedentary lifestyle, immobilization, inadequate calcium intake, alcohol, nicotine, and caffeine abuse, and premature menopause.
Treatment often depends upon slowing the aging process or the loss of mineral content from the bones. Unfortunately, often the diagnosis is made at the time of fracture of a critical long bone, and diagnosis at this time is difficult to treat or to slow the progress of the disease.
Okay, osteomyelitis is a serious infection of the bone that requires aggressive antibiotic treatment. It's generally caused by bacteria infection or viruses or fungal infection, and it's characterized by inflammation, swelling, redness, pain, and localized heat and tenderness. Conditions that need to be ruled out to make a differential diagnosis include toddler's fracture, which is a twisting fracture of the arm, Caffey's disease, an idiopathic disease that can cause fever, swelling, and periosteal elevation, just to name a few. Individuals most likely susceptible to osteomyelitis are those with sickle cell disease, immunodeficiencies, or malignancies. In infants and children, osteomyelitis can develop as a secondary infection from streptococcal pharyngitis, also known as strep throat. So that's something to, again, be on the lookout for. So what are some of the treatments? Well, long-term antibiotic treatment is recommended. Increased intake of proteins and vitamins A, B, and C, along with bed rest and control of chronic conditions, and immobilization of the affected part. The danger here is that as the infection spreads to the deeper tissue, that it could enter the bloodstream, and that could lead to sepsis, which could lead to multiple organ dysfunction and death. So let's take a listen to osteomyelitis.
Osteomyelitis is an infection of the bone. There are a number of ways it can occur. Open fractures or fractures that puncture the skin, blood-borne infections. Antibiotics can be given intravenously or by mouth, typically for 4 to 6 weeks at a time. Along with picking the right antibiotic, you have to get all the infected tissue removed. At the St. Francis Wound Healing Center, physicians there are trained to recognize and promptly diagnose osteomyelitis and related infections. They can serve as the hub for consultation between surgery and infectious disease or other specialists that might become involved. If one has a chronic condition, will benefit from hyperbaric oxygen therapies.
Powerful, innovative medicine for more than 130 years. St. Francis Medical Center.
From anatomy to anesthesiology, from pathology to pharmacology, from microbiology to medicine, a one-man resource to the world of health sciences. Welcome to Dr. Paul's Medical Lectures. A practicing physician, Dr. Paul offers you essential insights on diseases afflicting millions of people around the world. For today's lecture, here is Dr. Paul.
Okay folks, today I want to discuss a few minutes about osteomyelitis. As first of all, you see, osteomyelitis is basically infection of the bone, and most commonly the most common organism that causes this condition is Staphylococcus aureus. I mean, there are situations like an open injury to the bone, such as an open fracture that ends piercing the skin, or sometimes infection coming from other places in the body like pneumonia or urinary tract infection could bring bacteria into the vicinity of the bone and starts osteomyelitis. And sometimes even minor trauma or poor dentition. Then in a patient with the poor dentition, the bacteria starts traveling in the bloodstream and reaches the bone and cause osteomyelitis. The other thing you can think of is chronic wound infections. Like chronic wound infections also cause osteomyelitis. So osteomyelitis is a common condition, and there are certain risk factors like people with diabetes, people with hemodialysis or weak immune systems, people with sickle cell disease or intravenous drug abuse, or even elderly patients. So they are at more risk for osteomyelitis, and the symptoms they usually come with are pain in the infected area or the swelling, and fever, nausea, drainage of pus. So in this X-ray, we can see some of the most basic features of osteomyelitis. You take a close look at the tip, you can see that cortical thinning. That's very commonly seen. You see that cortical thinning is it is an indication, it's a clear sign of osteomyelitis.
Thanks for listening. For more medical videos, please visit us at www.drpaul.org and take time to browse through hundreds of health videos we regularly post on our site. If you are preparing for USMLE, PLAB, and other medical exams, make sure you visit our website to browse through our videos explaining the essential points you need to know before taking these examinations. For more information, visit us at www.drpaul.org. Thank you, and may God richly bless you.
Okay, osteoarthritis is the breakdown and eventual loss of cartilage in one or more joints. Causes include the normal aging process, basically because you're born with all the cartilage you're ever going to have. The only thing that happens as we age is that we lose cartilage as chondrocytes die and their extracellular matrix wears away. There's also a hereditary component. Injury can also exacerbate osteoarthritis, as can chronic diseases such as diabetes and obesity. The most common form of arthritis is osteoarthritis. This is the arthritis that we're all going to get if we live long enough due to wear and tear on the joint. Body parts where osteoarthritis usually appears first include large weight-bearing joints, especially the knees, the hips, and the ankles. And if you think about it, it makes sense, right? Because those joints are going to bear most of the weight when you stand up and walk. Osteoarthritis is a growing problem in the United States today because of the epidemic of obesity, which places now undue stress and strain on these weight-bearing joints. Drug therapy can include the use of analgesics, muscle relaxants, NSAIDs, and we can also use intra-articular steroid injections for specific individual joints. Intra-articular hyaluronic acid can also be used to reduce pain in the affected knee joints. This is a precursor of synovial fluid, and so the idea here is to up the amount of lubricant in the joint and ease the pain associated with movement and increase range of motion. Fish oils have been suggested to have some anti-inflammatory properties that can ease some of the pain of osteoarthritis. And there's also food supplementation with glucosamine and chondroitin to reduce pain and stiffness in some patients. But a cautionary note on these supplements. Generally, a balanced diet will contain sufficient glucosamine and chondroitin to make adequate synovial fluid for our ease of motion of diarthritic joints. And so these claims that these supplements can decrease joint pain and increase joint flexibility are predicated on the notion that you lack these in your diet initially. So always keep this in mind before attempting to go out and buy expensive supplements in order to try and alleviate the problems associated with this condition. Signs and symptoms include spur formations on the fingers, degeneration of spinal vertebrae and pelvic joints. We diagnose this with radiographic testing to exclude other causes, and the treatment is to reduce inflammation and also to minimize the pain. So here's a look at arthritis.
More than 40 million Americans have arthritis. The Center for Disease Control in Atlanta, Georgia, predicts that number will increase to 59.4 million by the year 2020. Dr. Arlene Ross, a rheumatoid arthritis specialist, explains what arthritis is and why it is so painful.
The word means inflammation of the joint. And so it's an apt term because everybody understands what inflammation is, and everybody has experienced some inflammation, like an injury, a bee sting. So they know if that happens, it gets red, it gets warm, it gets swollen, and it hurts a lot. And so all of those things happen in the joint which has arthritis.
There are several types of arthritis, but osteoarthritis is the most prevalent. Affecting 15.8 million Americans, it is a degenerative joint disease where the cartilage covering the end of a bone deteriorates. Affecting 2.1 million Americans, rheumatoid arthritis is one of the most serious and disabling forms of this disease. The lining of the joint becomes inflamed in reaction to immune system activity in the body. Treatment varies, but usually consists of exercise, heat, or cold treatments, methods to protect the joints, and possibly surgery. Medications may be used to reduce joint pain and joint swelling may include acetaminophen, aspirin, and anti-inflammatory drugs. The most recent breakthrough in rheumatoid arthritis has been the development of antibiologics that target individual molecules to reduce inflammation.
Okay, rheumatoid arthritis is a different disease altogether. It's still an inflammation of the joint, but the cause is very different. It's an autoimmune disorder. Basically, antibodies are produced by the patient's lymphatic system that attack joint tissue and destroy it. The first signs are chronic inflammation and edema of the synovial membrane surrounding the joint. We see destruction of the cartilage and the adjacent bone. It can produce weight loss, fever, and malaise. Malaise is defined as basically a lack of energy. You also see joint pain and stiffness, especially in the morning, and bilateral joint tenderness, edema, erythema, and warmth. Let's go through each of those. Bilateral joint tenderness means that we have joint tenderness on both sides of the body, the right and the left. Edema, as we all know, is swelling. Erythema is redness around the joint, and warmth. Rheumatoid arthritis can affect only one or two joints, but more commonly it affects many joints at the same time because this is a systemic disorder. It can also cause more generalized inflammation that affects blood vessels, cardiac muscles, skin layers, and tissue around the lungs. It can appear suddenly without warning signs or very slowly with recurrent progressive attacks. Autoimmune diseases are often thought to be triggered by exposure to a cross-reacting antigen as a result of your activities of daily living. You may, for instance, come into contact with a pathogen or even an innocuous particulate that contains a collection of molecules on its surface that are similar to but not exactly like your own antigens. The result of this is an immune response against that antigen, which leaves you with a large population of antibodies that can potentially bind to your own tissues and initiate an immune response against things like joint tissue, connective tissue, and so forth. Very often autoimmune disorders are seen in clusters. Sometimes people with rheumatoid will also show symptoms of lupus or Graves' disease, so it's also thought that there's a genetic component to this condition as well. The treatments are aimed at reducing inflammation and pain, preserving joint function, and preventing joint deformity. Anti-inflammatory meds are the first choice for treatments. These include aspirins and NSAIDs and even corticosteroids if the symptoms are severe. Again, the reason that we prefer NSAIDs over corticosteroids is because we can use NSAIDs over a longer period of time without the deleterious effects on immune function. Disease-modifying anti-rheumatic drugs include gold compounds and penicillamine, as well as new biologic response modifiers. Special splints or devices can be used to improve the quality of life and allow greater independence. And again, the prognosis is best with early medical intervention. The struggle with all of autoimmune diseases is the fact that we're trying to suppress the immune system because the immune system is the causative agent here. And when you do that, you increase your risk for infection and disease. So it's very tricky to treat. Okay, gout is a chronic disorder of uric acid metabolism. It generally manifests as an acute episodic form of arthritis. The causes are overproduction or decreased excretion of uric acid, high levels of uric acid in the blood, and high levels of uric acid in synovial fluid in joints and tissues. Remember that the synovial fluid is the lubricant around a joint within bursa and in tendon sheaths. Areas of the body that gout typically affects include the hallux and distal areas of the body. The reason for this is that distal areas of the body, including the hallux or big toe, are colder than areas central to the body, and as the temperature of a solution drops, the solubility of a crystalline solution decreases, and as a result you form these solids. They come out of solution and they feel, for all the world, exactly like a bone spur. Very, very irritating. Very often individuals that are in the throes of gout can also exhibit something called uremic frost, which is basically uric acid crystals forming on the skin in distal areas of the body, the earlobes, the tip of the nose, the toes, the fingers, and so forth. Dietary modifications that can help in the treatment of gout include a low purine diet and adequate fluid intake. This means avoiding organ meats and red meats primarily. Dairy products have been shown to reduce the frequency of attacks and alleviate some of the symptoms of gouty arthritis. Kidney function is related to gout because certain malfunctions of the kidney can result in errors in uric acid metabolism. The body can produce levels of uric acid that are normal, but the kidney function is insufficient to remove the product from the blood, and as a result it begins to accumulate, and we have the typical symptoms that we associate with gout. So what are the treatments? Well, bed rest to reduce pressure on the affected joints, applications of ice to the inflamed joints, NSAIDs and corticosteroids, and low purine diets, as well as frequent fluid intake, and anti-hyperuricemic meds, basically ways to keep those uric acid crystals from forming. The pain can be acute and severe with mild systemic symptoms, and the treatment with pain medication is usually urgent with gouty arthritis. It's very, very painful if you've never had it. So here's a look at gout.
My name's Philip Conahan. I'm a rheumatologist and I work in Leeds, predominantly at Chapel Allerton Hospital. Gout is a recurrent painful arthritis, probably the most painful arthritis we know. It predominantly affects males in their 40s, and it is associated with a number of conditions such as obesity, high alcohol intake, high lipids in the blood, and probably genetic factors that we don't understand too clearly. The major problems with gout is first the acute painful arthritis itself, which is very painful, and the typical onset of an acute attack of gout is waking at 3 or 4 in the morning with excruciating pain, usually in the big toe or ankle, such that you can't even put a sheet on the affected area. So it's normally exquisitely painful and tender. There is a range of metabolic associated diseases that come in association with gout. So gout is a warning to look at whole lifestyle issues, not just the arthritis. It often starts in big toe and ankle, but over time it can affect knees, wrists, hands, elbows, and as well you can get hard deposits of crystals, of these uric acid crystals, deposited in your joints and under the skin. So you get lumps on your elbow or little white crystals in your ears. The management of gout involves management of lifestyle factors and then treatment of acute and chronic attacks. For the lifestyle factors, we look at weight loss, reducing alcohol intake, especially of beers, which are more prone than wine to causing gout, reduction in shellfish and meat intake, which are foods that are associated with high levels of uric acid after digestion, and looking at having checks of blood pressure and cholesterol and triglyceride, the fat levels in your blood, so that all these things are checked. Treatment of acute gout generally involves drug treatment, and the commonest drugs used are non-steroidal anti-inflammatory drugs such as ibuprofen, diclofenac or indomethacin, and colchicine, which is an old drug which also helps gout. Another treatment that can be useful for people who can't tolerate anti-inflammatory drugs or colchicine, and both have significant side effects, is some intra-articular, a small injection of steroid, cortisone-like steroid, into the joint itself, or sometimes a small dose orally of cortisone for a few days will help settle the acute arthritis down. What most people want after they've had a couple of attacks of gout, we know that their risks of getting chronic gout is high. We want to stop them having the acute attacks, the joint damage and the long-term problems, and to stop people having gout, you really have to go onto another drug to reduce your uric acid levels down so low that you will not have more gout attacks. This is a condition that we can do a lot for, and really people can be very involved with their own treatment and look after themselves a lot better.
For more information, visit www.nhs.uk.
Okay, Hallus valgus and Hallus rigidus. What we're talking about here is deformities of the metatarsal phalangeal joint, shown in the inset over here. Hallus valgus is a localized area of enlargement of the inner portion of the metatarsal phalangeal joint at the base of the big toe. While Hallus rigidus is a stiff big toe that develops as a result of degeneration of cartilage in the first metatarsal phalangeal joint. So instead of this thing being cocked out to an angle, it's basically one solid, immovable digit. Some of the possible causes of bunions include foot disorders that we've characterized, Hallus valgus, in which the great toe is positioned inward towards the midline of the body. Arthrodesis and arthroplasty can be used to treat some of these disorders. Arthrodesis is fusion of the joint to relieve pain, while arthroplasty is replacement of the destroyed joint with a plastic prosthesis or an artificial joint. The role that footwear plays in the treatment of bunions and Hallus rigidus is that with proper footwear, bunions often can be tolerated without surgical intervention. If the footwear is abrading the toe, it could result in inflammation and secondary infection. And the danger there, of course, is that bacteria could enter the bloodstream and we could have sepsis, and the fallout from sepsis, which is multiple organ dysfunction and perhaps death, right? Anytime you do not treat an infected wound, you run that risk. Okay, symptoms are painful bunions. The metatarsal phalangeal joint becomes stiff, painful, and swollen. The treatment is to wear shoes with more room, use ice to reduce inflammation, anti-inflammatory agents such as NSAIDs and in some cases corticosteroids can be used. And for Hallus rigidus, we try to remove bone spurs in order to decrease inflammation. Okay, temporomandibular joint syndrome is a symptom of complex conditions related to inflammation, disease, or dysfunction of the temporomandibular joint. Well, what is the temporomandibular joint? It is the articulation between the mandible and the temporal bone. We often see clicking sounds during chewing, severe pain or aching, and tinnitus or deafness can be present. What this can also do, this can also be the result of an abnormal bite known as malocclusion. Occlusion is the relationship of the upper teeth and lower teeth in the mouth when they're closed. In malocclusion, what happens is we have difficulty chewing because we don't have proper interdigitation of the molars, the incisors, the canines, and so forth. And so what happens is that we get protrusions of teeth in the upper jaw hitting protrusions in teeth in the lower jaw. And the danger here is not only is it painful, but it can also damage the enamel and lead to tooth decay. Symptoms include clicking sounds during chewing or severe pain or aching made worse by chewing. We also see tinnitus. This is ringing in the ears, or in some severe cases we could even have deafness. Common treatments include braces for minor problems, extraction of teeth, and surgical removal of parts of the jaw. Another treatment is combining crowns or bridges to replace the missing teeth. Common treatments, usually 3 to 5 days of mandibular immobilization. NSAIDs are sometimes used, and patients can wear appliances such as a Imago splint to prevent grinding of their teeth. Jaw misalignment in TMJ is treated with a plastic bite plate that can be used to align the jaw. Physical therapy is sometimes used, as well as stress counseling and muscle relaxants. As a last resort, TMJ arthroscopy, joint restructuring, and replacement are sometimes considered. So here's a look at TMJ.
Let's look at our animation model. We'll call her Sue. As we look inside to see Sue's muscles, bone, and teeth, we see how a healthy bite and jaw joint work together. As the mouth opens, notice how the jaw bone rotates in the joint but stays braced against the skull with the cartilage disc cushioning between the two bones. As Sue closes, notice how the jaw rotates back, staying braced and cushioned at all time until all teeth come into contact at the same time. At the end of the chewing stroke, or opening and closing cycle, all the teeth have come together into the bite and the jawbone and disc are braced against the skull. What would it look like if Sue had a bite problem? Her jawbone starts off braced in the joint, but as she closes, her teeth come into contact prematurely in the back so that in order for the rest of her teeth to come together, her jaw has to come out of its socket, down and backward to avoid the early contact, which can be damaging and painful to the teeth. This is why we say that Sue has an unstable joint and is not braced throughout the opening and closing cycle. During the daytime, Sue's brain programs her muscles to make sure that the bite always comes together evenly, avoiding the early tooth contact in the back of the mouth by keeping the jawbone out of the joint socket. During sleep, the brain wants to rest and not worry about constantly programming the muscles, so instead it tells the muscles to either clench or grind the teeth so that they stay locked together. The jaw stays out of the socket all night and the muscles of the head and neck are working constantly during sleep. Since these muscles get overworked every night, they become fatigued, leading to spasms and inflammation. The result of the chewing system being constantly overstressed is breakdown of the teeth, gums, bone, and joint, and finally pain such as headaches and migraines, neck and shoulder pain, or popping and clicking of the jaw joint, among other symptoms. With an orthotic that bioaesthetic dentists call Imago splint, the jaw-bite relationship can be stabilized. Notice how the jaw joint is staying braced in the joint against the cartilage disc when the teeth bite against the Imago. Sue has been treated with the Imago splint to relax the muscles and let the jaw joint stay in its proper location. This is a diagnostic process that helps the dentist and patient learn what is causing the pain and what could change if the jaw joint stays in place. From this information, a final treatment can be formulated. Treating this problem will result in the bite and jaw joint becoming healthier and the muscles getting well-deserved rest. The result is that Sue will probably feel and sleep much better.
Okay, now we're going to branch into a completely different class of disorders. These are diseases of the nervous system. And the first disease we're going to talk about is muscular dystrophy. This is a rare disorder characterized by progressive degeneration and weakening of skeletal muscles. Often contractures develop due to the immobility of muscles or joints caused by shortening or wasting of tissue or muscle fibers. These are generally genetic defects. The most severe forms are sex-linked recessive defects due to a mutation in the dystrophin gene. This is Duchenne's muscular dystrophy. This protein is involved in maintaining muscle integrity by transferring the force of contraction to the connective tissue around the muscle. It's more common in males because it is X-linked. As a result, you only need one bad copy of the gene for the disease to show up. The treatment is supportive and long-term, and the prognosis for the most severe forms are poor. You generally see death 10 to 15 years after onset from heart and lung problems. Duchenne is the most common form of the disease. Signs and symptoms are usually present by age 5. The muscles atrophy and walking and breathing become difficult. Mobility becomes more compromised and contractures develop, and sometimes you also see mental impairment. Physical therapy, exercise, surgery, and orthopedic appliances may help to minimize deformities and preserve mobility. It's diagnosed by biopsy and electromyography, as well as elevated creatine kinase levels in the blood. And there's no cure because this is something present at fertilization. So this is a video that's going to talk about some of the different forms of muscular dystrophy. We just touched on Duchenne's, but here is a little look at some of the other forms of dystrophy as well.
Muscular dystrophy, MD, refers to a group of genetic diseases characterized by progressive weakness and degeneration of the skeletal or voluntary muscles, which control movement. Major forms of MD include myotonic, Duchenne, Becker, limb girdle, facioscapulohumeral, congenital, oculopharyngeal, distal, and Emery-Dreifuss.
Well, my name is Jack Epling. I am a realtor. We've been in real estate for 33 years. And I'm a patient of Muscular Dystrophy Association. I have the type called limb girdle. And it affected me more likely when I was in my 20s, diagnosed when I was about 37 years old. There are 9 types of muscular dystrophy, and mine is one of the most least severe. People don't understand that there's so many types of muscular dystrophy. There's 40 neuromuscular diseases total, and they all affect people to a different degree. Some, it's very minor, they can cope with it during the years, and they're not going to get into a wheelchair, they may not even walk with a cane. But one is they have, is Duchenne's muscular dystrophy, which young boys get, and life expectancy used to be at 16. Now they've been extended up into the early 20s. I personally do not have any pain at all, because you have someone with Duchenne's, and the spinal weakens, and they bend over, and they become, harder for to breathe, and they do have more physical problems in some muscular dystrophies. Because getting in and out of bed, I need assistance. Not getting out of bed, but getting into bed. With the wife and I figured out an easy method for her to help me get in. I can get in and out of the shower on my own because I have a bench in there, and I'm capable of moving myself in and out, which is not always the case, but in my case that's true. When I first had muscular dystrophy, it was a shock. It had to be to anybody. But I have always felt, God given me a life here to, do what I can on this earth. And I just got maybe one more little rock to carry around or something, but I feel that I've been very fortunate.
Okay, tetanus is a different kind of disease altogether. It's an infectious disorder. It's caused by the bacteria Clostridium tetani, and the symptoms are the patient is extremely feverish, has profuse sweating, a stiff neck, and a tight jaw. The cause, again, is the bacteria Clostridium tetani spread through contact with open wounds. A perfect example would be the classic puncture wound. The bacteria produces a nervous system toxin that inhibits GABA release and results in muscle spasms. GABA stands for gamma-aminobutyric acid, and it's a type of neurotransmitter. The incubation period is from between 3 days to 3 weeks. And the treatment is sedatives, muscle relaxants, tetanus shots within 72 hours. And the complications are a 35% mortality rate, and the reason for the mortality rate is if it's allowed to spread, the infection will eventually reach the diaphragm and the heart, and at that point the vital signs will stop. Infants are commonly given the diphtheria, tetanus, pertussis vaccine in a schedule of 4 doses at 2, 4, 6, and 15 to 18 months of age. Another dose is administered at 4 to 6 years of age with boosters every 10 years or after a presumed exposure to the bacteria. A ganglion cyst is a fluid-filled benign tumor on a tendon sheath near the wrist. So let's take a listen to ganglion cysts.
Hey, this is Dr. Newhouse again. I want to talk to you today about ganglion cysts. If you've had a ganglion cyst, then you know exactly what it is. A ganglion cyst is kind of like it sounds. It's a cyst. A cyst is a fluid-filled object that is under the skin. It's very soft in most cases. Where I see ganglion cysts on the feet are over the top of the foot more often than not, or on the front of the ankle. A cyst will form from pressure and irritation of the underlying soft tissue structures. A ganglion cyst comes from either the tendon sheath. A tendon is what connects the muscle to the bone, and there's a sheath that covers our tendons to allow them to glide, and that sheath will produce fluid so that the tendon can move smoothly. If there's injury to the sheath of the tendon, it will form like a little water balloon and it will bubble up. And the more active you are, typically the larger it is. So people will have swelling in the top of the foot or the front of the ankle. You can also get them on the wrist. With increased movement, you're going to have more fluid produced. Therefore, you're going to have a little bit bigger cyst. And it can change throughout the day. However, when it gets large enough, it'll just kind of stay at a large size. It becomes painful because there's a bunch of nerves that run over the top of the foot. And when that nerve gets pressure on it from underneath, pushing up from the cyst and then the shoe coming down on it, it causes pain. And they can be very painful. They can also be for the most part, very easy to treat. You need to pull the fluid off, obviously is the first thing to do. And then I'll inject them with cortisone. That cortisone can get the sides, I like to describe it as making the sides of the cyst kind of sticky. So as you pull that fluid out, put the steroid in, the sides get sticky, that water balloon will collapse on itself, and it can heal up and go away. However, cortisone shots probably only work about half the time. In other cases, people do need surgery to actually go in and remove that cyst and repair that tendon sheath that it's coming from. The other source can be the joint capsule. Joints also produce fluid and allow the bones to move smoothly together or against each other. And they have a little covering, kind of like the same water balloon idea. And when that's injured, it can produce that. So you have to find the source of the cyst if you surgically go in and repair that and stitch that up. And in some cases, even when you do that, they can come back. More often than not, though, the surgery is very successful and it can eliminate the problem forever. If you have more questions on ganglion cysts, don't be afraid to give us a call. I'll be happy to see you and see if that really is what you're suffering from. Thanks.
Okay, now neoplasms, we're basically talking about normal tissue becoming cancerous. Primary neoplasms of the musculoskeletal system are usually uncommon. They're typically secondary events that result from metastasis from a cancer that has its origin in the lungs, breast, or in the prostate. So some of the musculoskeletal neoplasms that are of interest here are bone tumors. This is any abnormal growth, whether benign or malignant, in the bone. If they're chondrogenic, they originate from cartilage. If they're osteogenic, they originate from bone. And if they're fibrogenic, they originate from fibrous tissue. A muscle tumor is a neoplasm that's a benign or malignant sarcoma that can arise at any site in the body. The most common type of primary bone neoplasm is an osteosarcoma. The most common presenting complaint for bone tumors is pain. Pathologic fractures are essentially events that can reveal bone tumors. Radiographic studies can reveal osteonecrosis or increased ossification or calcification. The bone tumor weakens the bone and makes it susceptible to fracture when subjected to a very slight strain. Areas of the body that are most commonly affected by muscle tumors include the extremities, the head, neck, trunk, and the retroperitoneum, basically the area inside the body behind the peritoneal membrane. Symptoms: malignant tumors have characteristic signs. Generally, there's a palpable mass and dull localized pain due to pressure on nerve endings. Often they're revealed by pathological fractures, commonly in the acetabulum or the proximal femur. And again, these are weight-bearing joints, and so this is not a surprise. If those bones are weakened, it's going to show first in these particular areas of the musculoskeletal system. Diagnosis is made with radiography, MRI, CT scan, and biopsy. Also, if there is elevated serum alkaline phosphatase, this can be an indication of a neoplasm, along with elevated serum calcium. The treatment is surgical excision and chemotherapy and radiation therapy or immunotherapy in conjunction with surgical excision. Most muscle tumors are benign, fortunately, so they tend not to spread. Okay, a fracture is caused by stress on the bones that results from a traumatic insult to the musculoskeletal system, severe muscle spasm, or bone disease. Some of the technologies used in diagnosing fractures, essentially we can use MRI, we can use X-ray. Pain accompanies most fractures, along with edema, tenderness, discoloration, and an inability to move the affected part. In some instances, a deformity of the affected part is noted. The location of the fracture and the type of fracture are determining factors in the symptoms and signs. A complete history and physical are followed by radiography of the affected structure. Bone scans and MRI aid in determining the diagnosis, and underlying pathologies are investigated and diagnosed. Sometimes this can require a bone biopsy. Again, we take an actual sample of the affected tissue, examine it under a microscope for changes in cell structure that are indicative of a disease state. Some of the immobilization techniques we use are simple cast, cast with sling, splinting, elastic bandage, soft cast, and traction. In every case, the break has to be reduced, meaning that the ends of the bone have to be set so that when they knit, the structure of the bone can assume the orientation that it had prior to the accident. If this doesn't happen, what you'll have is a bone that has an abnormal shape, and as a result is likely to break again. And also there's going to be complications that can ripple all through the musculoskeletal system. You can have pain with joints that are distal to the area of the injury. This is something that we have to address as soon as possible. An open fracture, which is where the bone protrudes through the soft tissue, needs to be treated immediately because of the increased risk of infection. It requires, again, reduction and splinting and immobilization techniques. So let's take a look at fractures.
The skeletal system is made up of 206 bones and provides support, allows for movement, and protects the internal organs of the body. Sometimes too much pressure is applied to a bone that results in what is known as a fracture. Fractures are often classified as either open or closed. An open fracture is a fracture where a piece of the broken bone pierces through the skin. This can be dangerous because the bone is exposed, increasing the risk of infection. A closed fracture is a fracture where the bone is broken but does not come through the skin. A compression fracture is a closed fracture that occurs when two or more bones are forced against each other. It commonly occurs to bones of the spine and may be caused by falling into a standing or sitting position or a result of advanced osteoporosis. An avulsion fracture is a closed fracture where a piece of bone is broken off by a sudden forceful contraction of a muscle. This type of fracture is common in young athletes and can occur when muscles are not properly stretched before activity. This fracture can also be a result of an injury. An impacted fracture is similar to a compression fracture, yet it occurs within the same bone. It is a closed fracture that occurs when pressure is applied to both ends of the bone, causing it to split into two fragments that jam into each other. This type of fracture is common in falls and car accidents. All fractures must be taken seriously. If you think that a bone has been fractured, you should seek immediate medical attention.
Okay, other injuries that can occur. If we look at some of the different types of fractures, their diagnosis depends on the location, severity, the type, and the cause of the fracture. A simple fracture of a long bone requires reduction and immobilization. Again, reduction is to get the ends of the bones to set, and immobilization, basically you cannot use the affected part until it knits. A compound fracture requires cleaning, debriding, reduction, and immobilization. Debriding means to remove dead or damaged tissue. Reduction, again, is to set the ends of the bone, and immobilization, again, not using the affected limb or the affected bone. Internal fixation is used for open reductions. That's where the bone is protruding through the skin, and what we have to do there, again, is not only set the bone, but we have to clean the wound, and we have to close the area where the bone protruded through the soft tissue. So here's a look at some of the different kinds of fractures. The way this is going to work is that the letters of the alphabet are going to run A, B, C, and D, E, F, G, H, I, J, K, and L. Okay, so follow the diagrams as we go through each of these different types of fractures. A, up here, this is a closed or simple fracture, and the overlying skin in this case is intact. You can see that this is a break across the long axis of a long bone. B, shown here, is an open or compound fracture. The skin overlying the bone ends is not intact, so we have a protrusion through the soft tissue of the bone. The risk here, of course, is infection of the bone, better known as osteomyelitis. C is a longitudinal fracture. This extends along the length of the bone, okay, so going along the long axis here. D here is a transverse fracture. The fracture is at right angles to the long axis of the bone. E is an oblique fracture. The fracture extends at an angle to the long axis of the bone. F is a green stick fracture. The fracture is on one side of the bone and the other side of the bone is intact. G is a comminuted fracture. Okay, so here the ends of the bones are splintered or crushed, usually because the ends of the bone are driven into each other. This is an injury that's the result usually of an impact. H is an impacted fracture. The fractured ends of the bone are driven into each other, and the result again is that the ends of the bones are crushed. Okay, so if we move down, I is a pathological fracture. The fracture results from weakening of the bone by disease. So very often we're not aware of any underlying bone problem until we actually have this event. J over here is a non-displaced fracture. The bone ends remain in alignment. K is a displaced fracture. The bone ends are out of alignment. And L is a spiral fracture. This results from a twisting stress to the bone, causing the break to wind around the bone in a spiral. Green stick fractures and spiral fractures are more common in the musculoskeletal systems of infants and children because of the increased protein content and the increased flexibility as a result of the musculoskeletal system. Other types of fractures. M here is a compression fracture. Excessive pressure causes the bone to collapse. Here you can see a compression fracture of the vertebra here. This is anterior aspect, posterior aspect. This is superior and inferior aspect. N is an avulsion. Okay, this is the tearing away of a muscle or ligament accompanied by a tearing away of some of the bone fragments. So we pull the soft tissue out of the bone and we take some of the bone with it. O, over here, is a depression fracture. The bone fragments of the skull are driven into the brain. Again, very serious injury. Strains are injured tendons, muscles, or other tissues that result from overuse, overstretching, or excessive forcible stretching of the tissue beyond its functional capacity. The way I remember this, the T in strain is like the T in tendon, so strains tend to address tendons and other soft tissues. Sprains are acute partial tears of a ligament. Now the reason that these heal very slowly is because ligaments have a much poorer blood supply than tendons or muscle. As a result, often surgical repair is the only method to fix an acute sprain or, in some cases, a rupture. The more serious injury is the sprain due to the lack of blood supply and the longer time it takes to heal. Strains and sprains have common symptoms. These include localized pain, weakness, numbness, and possibly edema around the site of the injury with both strains and sprain injuries. Using, moving, or bearing weight on the affected limb or part is difficult and sometimes impossible for the patient. Too much pain is involved. The difference between an acute and a chronic trauma is that an acute trauma will be caused by a catastrophic accident, say a car accident, a collision of some kind, whereas a chronic trauma results from overuse. Examples of these are sports-related injuries as a result of repeated overuse of a particular movable joint. How long does it normally take for a sprain or strain to heal? Between 2 to 4 weeks. Obviously longer for sprains than for strains, again due to the decreased blood supply. And you can tell that ligaments have a decreased blood supply if you just look at the color of ligaments. Ligaments tend to be very pale in color, while tendons tend to have a pale pinkish hue. So how do we treat? Elevation and rest of the affected limb, immobilization with elastic bandage, application of ice, analgesics, and anti-inflammatories. NSAIDs. Other types of injuries include dislocations. This is the forcible displacement of a bone from its joint, causing a loss of function. And treatment is to reposition the joint within half an hour of injury. Again, that's what we call, again, reduction. Three most common causes of dislocation are severe injury, congenital weakness, and arthritis. The possible consequences from an untreated dislocation are damage to the joint and weakness, along with osteoarthritis. The joints that are especially susceptible during to recurring dislocation include the shoulder and the hip. And again, the reason for that is their greatest range of motion compared to all the other diarthroses in the body. The shoulder and the hip have the most degrees of freedom in terms of movement. Ehlers-Danlos is a genetic disorder. It is an autosomal dominant disease of connective tissue that's characterized by joint and skin laxity. Basically, it's very easy for people with Ehlers-Danlos to dislocate their joints, their diarthroses. A severed tendon can be caused by an injury or a laceration. That's a cut. It can involve the forearm, the hand, calf, or the foot. The severed ends snap away from each other. The symptoms include immediate severe pain, inflammation, and immobility. The treatment is tenoropathy, which is to suture the two ends of the tendon back together to give them a chance to heal. Lower back pain can be a very common disorder. It can be acute or chronic. Treatments include moist heat, analgesics, anti-inflammatories, again NSAIDs, and muscle relaxants. So let's take a listen to lower back pain.
One of the common conditions that we see at Coordinated Health is spinal stenosis. People often ask, what is spinal stenosis? And I'll use a model to kind of describe what that is. Now this is the site where spinal stenosis actually occurs. And spinal stenosis can occur for several reasons as we look at the spinal canal. There's a ligament which sits here in the back of the canal called the ligamentum flavum. As we age, that ligament can thicken, and as it thickens, it can compress the nerve roots inside the spinal canal. Secondarily, again, looking from the side at these cartilage discs, it's not uncommon as we age for these discs to start to degenerate. As they degenerate or start to thin, they can then bulge back into the canal. And as they bulge in the canal, you can imagine that the canal narrows over time and starts to compress the nerves. And finally, the third component that can contribute to spinal stenosis are the facet joints, or these little joints in the back. Now, these joints are just like any other joint in the body, and they too can or are susceptible to arthritis. And when arthritis occurs in these joints, the bone spurs can grow into the canal, and as the bone spurs grow in, they can pinch nerves or also narrow that spinal canal. So those are the three main components of spinal stenosis that would cause narrowing of the spinal canal, both centrally and where the nerves exit on the side.
The classic spinal stenosis patient has narrowing of the nerve hole. When that person stands upright and walks through the mall or the supermarket, they're actually leaning their lower back backwards a bit, making those nerve holes a little bit smaller. And that irritates those nerves, and eventually as that person walks a bit, they get pain, usually down the backs of the legs. It can be down through the hamstring and even down into the calf. When someone with classic spinal stenosis sits, that pain goes away almost instantly because they're opening up those nerve holes and relieving the pressure on those nerves. The other classic sign, which patients will often tell us before we even get a chance to ask, is what we call the shopping cart sign. And that's the individual that goes to the supermarket and grabs the shopping cart no matter how many items they have, and they do great if they're walking with a shopping cart. They can walk all day long. As soon as they get rid of that shopping cart and walk straight up, they have a problem. Most people believe it's because they're somewhat resting their spine as they lean forward on the shopping cart. Actually, what's happening is those individuals, unbeknownst to them, are bending their spine forward a bit and gapping the space around the nerves in the back. So they're automatically relieving the pressure and the irritation on the nerves and relieving their leg symptoms. When a patient comes in with complaints, we're not quite sure exactly what's happening. We use our physical exam to both try to elicit what may be the pain source as well as rule out any dangerous problems. We test things like neurologic function. We want to test the muscular strength and the sensation and the reflexes in the legs. Those neurologic functions relate to how the nerve roots are working as they exit the spine. We then test things like spinal motion in forward flexion, in extension, in side bending, to see whether or not there's any restrictions within the joints, the muscle or disc structures of the spine as we try to elicit what the pain source may be.
Just above this normal disc, we can see an abnormal lumbar disc that is bulging out into the spinal canal. And as it's bulging, we can see that it's actually narrowing the spinal canal compared to the distance that we see down here with the normal disc and spinal canal. This narrowing within the spinal canal right here is called spinal stenosis, and it's a potential site of impingement on a nerve. These are the nerves then that extend down through the spinal canal. They exit and will go down to the leg. And so the nerve actually becomes compressed here, and as it's compressed, someone can experience pain down the length of that nerve as it extends from the back all the way down to the leg and in some cases into the foot. And this would be the site of the original compression.
Treatment options for spinal stenosis, again, just like any other condition, span the entire spectrum of lumbar treatment, starting from the most conservative and ending with the most aggressive. Most conservative is medical management, medication treatments, anti-inflammatories, ice, muscle relaxers for the muscular pain that goes along with this, and things like physical therapy, chiropractic care to manipulate, stretch, and strengthen the spine to support the structures a bit better. Decompression therapy can be an option for spinal stenosis by decompressing the spine, or what was known as traction. You can get some blood flow back into the discs, help the discs reshape and heal a bit better. And certainly our interventional treatment options such as epidural injections or joint procedures are very common necessity in the spinal stenosis patient because it's often those structures that need to be treated and calmed down to alleviate the patient's symptoms. Surgery is warranted if conservative and interventional care fails. But the surgeries for spinal stenosis range everywhere from minimally invasive procedures using very small incisions, very small decompressive surgeries to open the spaces up, to more involved fusion surgeries to remove more bone or more disc space and stabilize the spine if need be.
There are two goals in treating your back pain. The first is to treat your acute pain, and the second is to address the functional limitations that are causing you pain. You can't treat just your symptoms if you don't know what's causing them. Chiropractic care is an important tool in reducing the acute pain, while physical therapy addresses your functional limitations or impairment. But both therapy and chiropractic care are education-based. They focus on your ability to move in all planes as well as to maintain correct posture. Maintaining that correct postural alignment includes keeping your feet straight, your hips tucked in, your shoulders back, and your chin tucked. Individual, comprehensive, progressive physical therapy programs focus on 4 areas. The first is to improve functional core strength. This provides you a firm base so your limbs can generate force and motion. The second is functional stretching. This is to regain or improve the range of motion and flexibility of the muscles in your back in all directions. The third is functional endurance. This is to improve your muscular endurance and your ability to maintain correct postural alignment. And finally, the last area is functional balance and proprioception. Proprioception means improving your ability to maintain balance in all planes. At Coordinated Health, we work as a team in your education and treatment, but you're the key member of that team. Maintaining a pain-free back means working hard to understand and apply the principles which we teach you. Stretching and strengthening your back on a daily basis will help prevent recurrences of back pain, allow you to move better, and improve the quality of your life. And that's the art of medicine.
Okay, herniated discs are a rupture of the nucleus pulposus, which is the liquid center of the intervertebral disc, through the annulus, which is the fibrous outer coating. When the nucleus pulposus extends into the inner annulus only, it's considered a bulging disc, but when it extends through the inner and outer annulus, it's considered to be a herniated disc. The danger here is pressure on the spinal cord and pressure on the spinal nerves, and this is often accompanied by numbness or perhaps loss of function. It's also known as a ruptured or a slipped disc. The intervertebral discs, remember, are an important part of the amphiarthrotic joints of the spinal cord. The amphiarthrotic joints of the vertebral column, inside which the spinal cord runs. The danger is that because the spinal cord runs through the vertebral arch, that when the bulging disc presses on the spinal cord, you can produce damage to the nervous tissue. And remember that nervous tissue in the central nervous system does not regenerate or repair, whereas nervous tissue in the peripheral nervous system has a limited ability to repair damage. So let's take a listen to herniated and bulging discs.
Annually, more than 250,000 Americans undergo surgery to remove or repair herniated discs, a leading cause of back pain. Traditionally, this operation has proven to be painful and recovery time can last several weeks. However, Dr. Kevin T. Foley has co-founded a new technique for back surgery, which provides nearly immediate relief from pain, faster healing, and less hospital time.
The procedure is called a Metrix discectomy. It is a minimally invasive way to remove a ruptured disc from the low back, and Metrix stands for Minimal Exposure Tubular Retractor.
This new technology allows surgeons to repair herniated discs by viewing the affected nerves through a narrow tube inserted into a small incision in the patient's back. About 70 to 80% of patients who need herniated disc surgery are candidates for the Metrex procedure.
A typical patient who would be a candidate for this would have persistent buttock and leg pain from a ruptured disc or a bone spur that had failed to improve with a good trial of non-operative care.
On June 16th at 4 p.m., watch a live webcast of a herniated disc repair using the Metrex system.
Okay, what you're looking at here are some diagrams showing you how this injury occurs. Notice how in both diagrams, in B, the herniated disc, and in C, the area that's pressing on the spinal cord, can result in pain, numbness, tingling, and sometimes permanent damage. A herniated disc differs from a bulging disc in that it is pushed completely out of the annulus. But notice here where this is, again, the intervertebral disc. This is the spinal cord. These are the spinal nerves. There's the gray matter of the spinal cord surrounded by the white matter. And notice when the disc bulges out that you can impinge on, in this case, a spinal nerve, or if it were to bulge directly through into the open space that's formed by the vertebral arch, you could actually crush the spinal cord proper. And that could result in permanent damage and loss of function below the area of the injury. The symptoms: the patient experienced severe back pain. It can radiate from the back to the buttocks, the thigh, and the leg. And there's possible disability that can occur if the disc pinches or pushes against spinal nerves. Most herniated discs occur in the lower back, and the reason again for that is the increased amount of force. If you notice, and you look at the vertebral column, that the vertebrae get larger the further down the column you go, from superior to inferior. And the reason for that is that they're supporting successively greater and greater force. Again, they're working against gravity. So there's more body weight on the lumbar vertebrae than there are on the thoracic or cervical vertebrae. Sciatica is a pinching of the nerve roots from the sciatic nerve. The thing about the sciatic nerve is it's very large, has a very wide diameter, and so it's easy to impinge on it. Most herniated discs, again, occur in the lower back. The reason that the pain often radiates to other parts of the body is that the nerve roots in these areas serve the lower extremities, and so if you impinge on them, you're going to have problems receiving and sending information to the appendages. Bursitis is an inflammation of the fluid-filled sacs that you find around joints. Inflammation can also develop in other structures. The reasons for bursitis: this could be due to infection or repetitive motion. Again, itis is just an inflammation. The treatments include rest, analgesics, and application of cold and heat, so temperature therapy, and also steroid injections. So let's take a listen to bursitis.
Hi, I'm Dr. Kathy Stallworth, and I'd like to share with you my approach to bursitis, how I diagnose it, what I recommend for my patients. Bursitis is a very interesting issue. Basically, what a bursa is, this is a model of your shoulder. This is your shoulder blade, your collarbone sits in like this. This is the arm. I'm using this balloon to demonstrate a bursa. You've got these little bursal sacs that help to protect the joints. They're typically underneath the tendons where the muscles attach to the bones. And typically, the sacs are just, they're not very full. They may have a little fluid in them, but they're not very prominent. And again, they just kind of help to keep things moving, decrease friction. But what happens when you actually get a bursitis is if for some reason you get some impingement on the bursa can actually fill up with fluid even more. So someone with, say, a bursitis in the shoulder would have a bursa that was swollen. When you get this swelling, it can be quite painful. And some of the really common areas where we see bursitis are the shoulder, the back of the elbow, the lateral hip. and the knee. People with pain on the outside of the hip typically have trochanteric bursitis. And again, the trochanteric bursa normally sitting here, not inflamed, just nicely decreasing friction over the iliotibial band that runs from here in the pelvis down to the knee. And when it gets inflamed, you can imagine something like this. And again, stretching the band that's popping back and forth over the greater trochanter will significantly decrease your symptomatology. So one of the things about shoulder bursitis, I see shoulder bursitis in a lot of people who have rounded shoulders. What happens is when the shoulder's round, when you try to lift your arm, you can try this yourself, you'll feel a lot of impingement in the shoulder. It's that impingement that irritates the bursa that leads to inflammation that leads to pain. So one of the things I have people do is work on stretching through the front of the chest, bringing the shoulders back, and then creating a lot of space in the joint. Again, just this simple activity of working on the posture through here can decrease your symptoms of bursitis. We recommend rest. We also recommend ice. If this is an area where you can apply some compression, you may want to do that. If you're not responding to these conservative measures, I highly recommend you seek the services of a physician.
Okay, tendinitis, also spelled tendonitis, is an inflammation of a tendon that's usually caused by an insult or injury to the tendon and is often accompanied by pain. Calcium deposits can be present with tendinitis. Nonspecific tendinitis is often difficult to diagnose unless a thorough patient history reveals a precipitating event. So what are the treatments? Well, reduce pain and decrease inflammation using rest, oral anti-inflammatory drugs, the application of ice, and steroid injection. These types of conditions often occur in the shoulder joint, again, because the shoulder joint is the most movable joint in the body. Also, the shoulder joint features a lot of associated soft tissue that has to fit inside very narrow crevices between bony prominences. Examples being the acromion-corsoid processes of the scapula and the area of articulation between the clavicle and the acromion process in the lateral aspect of the shoulder joint. Also, the muscles that make up the shoulder joint, the supraspinatus, the subscapularis, the teres major, and the infraspinatus, all have connective tissue attachments to the humerus, and the room in there is often very, very tight, so it's easy for inflammation to produce extreme pain. The prognosis is unpredictable because treatment may not always alleviate pain or increase mobility. So here we get to our first repetitive motion disorder. This is carpal tunnel syndrome. Carpal tunnel syndrome is one in a cluster of disorders that result from repeatedly performing the same motion over and over again on a day-in, day-out basis, and this eventually results in inflammation of the accompanying soft tissue, pressure on nerves, and pain. Many of these injuries occur in the wrist and the hand because of the pressure combined with frequent and repetitive motion over an extended period of time. So let's take a listen to carpal tunnel syndrome.
Tying rebar is hard, physical work. It's also an example of a job that involves repetitive use of the wrist. Use that can cause problems such as carpal tunnel syndrome. Carpal tunnel syndrome is a condition that interferes with the use of the hand. It's caused when too much pressure is put on the nerve that runs through the wrist. To understand carpal tunnel syndrome, it helps to understand the anatomy of the wrist. The wrist contains tendons and nerves inside a narrow tunnel. This narrow tunnel, the carpal tunnel, has a fixed diameter. In carpal tunnel syndrome, symptoms occur when there is pressure on the median nerve. This pressure on the nerve, in the narrow tunnel of ligaments and bones, causes the symptoms. Some of the symptoms of carpal tunnel syndrome include numbness, tingling, and pins and needles. For more information on carpal tunnel syndrome, visit WorksafeBC.com.
Bounded by bones and ligaments, the carpal tunnel is a narrow passageway about as big around as one's thumb and located on the palm side of the wrist. This tunnel protects a main nerve to the hand and 9 tendons that bend the fingers. When pressure is put on the median nerve, it produces the numbness, pain, and eventually hand weakness that characterize carpal tunnel syndrome. Injury or trauma to the area, such as repetitive movement of the wrists, can cause swelling of the tissues and carpal tunnel syndrome. This type of injury may be caused by sports such as racquetball or from sewing, keyboarding, driving, assembly line work, painting, writing, use of tools, especially hand tools or tools that vibrate, or similar activities. The condition occurs most often in people 30 to 60 years old and is more common in women than men. Obesity, diabetes, and rheumatoid arthritis have been associated with an increased risk of carpal tunnel syndrome. Proper treatment usually can relieve the pain and numbness and restore normal use of the wrists and hand. Treatment may include wearing night splints on the wrist for several weeks. Additionally, the splints may also be worn during the day, and heat or cold compresses may be added. Other types of treatment include modifications in the work area, such as ensuring that the keyboard is low enough so that the wrists aren't bent upward during keyboarding, and modifying work duties or recreational activities. Medications used in the treatment of carpal tunnel syndrome include NSAIDs such as ibuprofen or naproxen, and the use of corticosteroids. Surgical treatment cuts into the ligament to relieve pressure on the median nerve. In severe cases, nerve conduction studies may be used to follow the recovery of the nerve. Surgery is successful about 85% of the time, depending on the severity of the problem.
Okay, plantar fasciitis, again another painful condition. It's an inflammatory response at the bottom of the heel bone, the calcaneus, and it's generally caused by overuse. Symptoms are pain on the bottom of the foot, feels sort of like an ice pick is being driven into your heel when you walk. Treatments include application of ice, the use of anti-inflammatory meds such as NSAIDs, heel pads, and cortisone. The flat tissue, the fascia, acts like a bowstring for the arch of the foot and attaches to the bottom of the heel. Conditions that need to be ruled out to make a differential diagnosis include reactive arthritis, inflammatory bowel disease, ankylosing spondylitis, and diffuse idiopathic skeletal hyperostosis. The people most susceptible to plantar fasciitis: obese individuals, people with flat or high-arched feet, or people who wear footwear that has poor arch support. So let's take a listen to plantar fasciitis.
Plantar fasciitis, the most common cause of heel pain. Plantar fasciitis is classically known for causing pain in the heel at the first step in the morning. The pain can feel like a stone bruise, a sharp dagger, deep throbbing, or a dull ache. Plantar fasciitis is the tearing, inflammation, and degeneration of the plantar fascia, a long ligament in the bottom of the foot. The inflammation is the result of small microtears within the plantar fascia. The inflammation causes pain at the inside of the heel where the plantar fascia inserts on the heel bone. The traction on the heel bone from stress of the plantar fascia may cause a heel spur to form. Although heel spurs are commonly seen on X-ray, they are rarely the cause of pain. The cause of plantar fasciitis is multifactorial. The combination of abnormal motion in the feet, usually overpronation, in combination with an unsupportive pair of shoes and overuse can cause microscopic tears in the plantar fascia and start the process. Some common conservative therapies for plantar fasciitis include icing, stretching, heel lifts, supportive shoes, weight loss, taping, orthotics, and night splints. An ice massage with a frozen water bottle for 15 minutes 2 to 3 times a day will both stretch the plantar fascia and decrease inflammation. Stretching is one of the more important treatments and should be done multiple times a day, including before stepping out of bed. A plantar fascia specific stretch has been shown to be the most beneficial. A heel lift can decrease the stress on the plantar fascia. Tight calf muscles lead to the heel coming off the floor early, and this places excess stress through the plantar fascia, which results in tearing, inflammation, and pain. Supportive shoes are one of the most important steps. A shoe which is too soft and flexible will strain the plantar fascia with each step. Think about a shoe as a brace to the ligament protecting it while it heals. Taping is a method designed to take stress off of the plantar fascia to allow it to heal. The method shown here is a low-dye strapping and can be an effective short-term treatment. Orthotics are rigid devices placed in the shoe and designed to control abnormal motion and prevent arch collapse. By placing the foot in the correct position, it will take stress off the plantar fascia and allow it to heal. Night splints can be very beneficial as they help keep the plantar fascia stretched out while you sleep. When sleeping, the foot is in a relaxed position. During the night, the calf and the plantar fascia contract and tighten. In the morning, the plantar fascia is in a tightened, shortened position. When full body weight is placed on the foot, the fascia becomes overstressed and tears. Night splints hold the ankle up and pull the toes back, stretching both the calf and the plantar fascia during the night, allowing the fascia to heal in an elongated position.
Okay, rotator cuff injuries. These are devastating. The four tendons of the rotator cuff are formed by the muscles of the shoulder and partially surround the head of the humerus and stabilize it in the glenoid cavity of the socket. Tears to this musculature, to this soft tissue, can limit the function of the shoulder. Two major causes of these types of tears include acute trauma and degenerative changes that accompany age. The usual treatment for acute rotator cuff tears are narcotics, acetaminophen for moderate pain, and anti-inflammatory medications such as NSAIDs. We also use rest and conservative therapy, including gradual physical therapy for rehabilitation. Minor tears can heal with restoration of function after several weeks. Athletes most susceptible to these types of injuries include pitchers, quarterbacks, and tennis players due to repeated stress on the shoulder joint. Now the knee joint is another very critical joint, very easily injured joint. The popliteal region of the knee is the back of the knee, and it's supported by a complex array of extracapsular ligaments external to the joint capsule that prevent the knee from rotating in other than its assigned axis when you use it. The lateral, collateral, and medial collateral ligaments keep the knee from bending in either a medial or lateral orientation. There are two intercapsular ligaments that are deep inside the joint capsule, so they lie inside the synovial fluid, and they attach to the distal head of the femur and the proximal head of the tibia, and they form a cross. And these two ligaments are the anterior and posterior cruciates. The ACL prevents hyperextension of the knee when the ACL is pulled tight. One of the most common sites of knee injury is a ruptured ACL, while the posterior cruciate ligament prevents the femur from sliding off the tibia and prevents the tibia from being displaced backward. The ability to lock the knees is an important aspect of bipedalism, the ability to walk on two legs. When the knee is extended to the fullest degree allowed by the ACL, the femur will rotate immediately on the tibia. This will lock the knee, and all the major knee ligaments are twisted and very tight. To unlock the knee, the popliteus muscle rotates the femur laterally and untwists the ligaments. And so here we're looking at a sagittal section through the knee joint. The knee joint has about 13 bursa. There's 4 anterior. These are the superficial infrapatellar, the suprapatellar, the prepatellar, and the deep infrapatellar. The popliteal region contains popliteal bursa and a semimembranosus bursa. And so here you can see each of these. Notice they're highlighted in red on this diagram. So there's the suprapatellar bursa up under here. Okay, there's the prepatellar bursa in front of the kneecap. The superficial infrapatellar bursa just in front of the tibial tuberosity, and the deep infrapatellar bursa that lies underneath it on the tibial tuberosity. And if you look inside the knee, you can see the meniscus, which serves to increase goodness of fit between the distal head of the femur and the tibia, and the articular cartilage, which absorbs a lot of the shock. Notice that there's not a lot of space inside this joint capsule, and as a result, if you abuse the knee, what happens very often is that the cartilage wears away, and this can result eventually in osteoarthritis. And here is a peek at the back of the knee and the front of the knee. This is the front, this is anterior aspect, this is posterior aspect, and what I want you to notice here are the collateral and the cruciate ligaments. Okay, so there is the lateral collateral or fibular collateral ligament, and here is the tibial collateral ligament. And so these stabilize the knee moving side to side. The fibular inhibits lateral movement, while the medial, the tibial collateral ligament inhibits medial movement of the knee. And you can also see there's a couple of transverse ligaments down here that also help to stabilize the knee joint, but the big players here in anterior-posterior stabilization are the cruciates. The anterior cruciate here can be seen because we've removed the kneecap so that you can see right through the front of the knee. Notice that it crosses in front from lateral to medial, while the posterior cruciate ligament crosses in the back from medial to lateral. And here, if you look at the back of the knee, you can also see these ligaments. There's the PCL, okay, and you can see the ACL that's crossing, and see how it disappears and then crosses in front. Okay. If we look at the top of the knee, this is the superior aspect, you can see the medial and lateral meniscus. These absorb shock and they help shape the joint. Okay, so here you can see where the anterior cruciate would have been. You can see where the posterior cruciate would have been. We've removed the femur, okay, and so you can see the lateral and medial condyles of the tibia, and this is where the distal head of the femur would sit. So what are some of the injuries that can affect the knee? Well, a torn meniscus is a crack or fissure to the meniscus cartilage in the knee. The symptoms include acute pain when putting full weight on the affected leg and knee, and snapping or clicking on flexion or extension. The treatment is to immobilize and elevate the affected joint, and also surgical repair. Cruciate ligament tears are located inside the knee joint, and the two ligaments that cross to stabilize the knee as a result of losing their connection have to be surgically repaired in order to knit. The two types of meniscus cartilage in the knee joint are the lateral and medial meniscus. The preferred technology for diagnosing a torn meniscus is arthroscopy. This is where we take a fiber optic camera and put it inside the joint capsule and look at the points of attachment for the ligaments. Arthroscopy is a surgical procedure used to examine structures within the joint using a tube-like viewing instrument called an arthroscope. The advent of this technique is only a few decades old. The arthroscope is a small tube that contains optical fibers and lenses. It's passed through a tiny incision in the skin into the joint to be examined. It's connected to a video camera that allows the interior of the joint to be seen on a television monitor and directs now surgical repair if that's necessary. Okay, shin splints are a painful condition involving an inflammation of the periosteum, the extensor muscles of the lower leg, and the surrounding tissues. The symptoms include inflammation, edema, pain on the inner aspect of the tibia, and the treatment is rest plus the application of ice or heat. And it's often the result of something called overpronation, basically where we rotate the foot too far medially and we increase the pain on the associated structures on the anterior aspect of the tibia. The two most common causes of shin splints are overuse and overpronation of the affected limb, The relationship of pronation to shin splints is that excessive pronation places abnormal stress on the calf muscles. This leads to the development of shin splints and tendon and ligament strain around the ankles and knees. Shin splints usually begin to appear with exercise, and they disappear after rest. Okay, Decker-Vane syndrome is a tenosynoviitis of the sheath or tunnel that surrounds the two tendons that control movement of the thumb. The tendons of the extensor pollicis brevis and abductor pollicis longus, which control radial abduction, present with a thickening and a transformation into a semi-solid state. This is an idiopathic condition, meaning we don't always know what the direct cause is. So here's a look at Decker-Vane syndrome. Okay, the symptoms include pain, tenderness, and swelling over the radial aspect of the wrist and difficulty gripping. The treatments include NSAIDs, steroid injections, the use of a TENS unit. Now, that stands for transdermal electronic neural stimulator, and what it does is it reduces pain because it interferes with the movement of the pain signal up towards the brain, and it can be used in conjunction with electrostimulation of the affected musculature. We also use deep heat and sometimes cold laser, which reduces prostaglandin production. Prostaglandins are a major trigger for inflammation. We can also use surgery to longitudinally open the first sheath in the dorsal compartment, as explained in the preceding video. Okay, myasthenia gravis is a chronic progressive neuromuscular disorder. It is an autoimmune disorder. Autoantibodies are produced against acetylcholine receptors in muscle cells, and what this does is this interferes with nerve transmission from the peripheral nervous system to the associated muscle. Ineffective nerve-muscle junction results in severe weakness, often appearing first in the face, difficulty talking and swallowing, droopy eyelids, and diplopia. The cause of myasthenia gravis isn't known with certainty, but most patients have thymus hyperplasia or tumor, so we believe that there may be some endocrine involvement. Thymectomy is usually indicated in these circumstances. The total standard treatment for patients with myasthenia gravis is acetylcholinesterase drugs and corticosteroids. Now, what the acetylcholinesterase drugs do is they affect the amount of time that acetylcholine spends in the synaptic cleft. The longer the acetylcholine spends in the cleft, the more likely that the nerve signal is going to be sent to the target. And corticosteroids, of course, are used to reduce inflammation. So here's a look at myasthenia gravis.
Myasthenia gravis is a neurologic condition that patients fail to transmit their nerve impulses in their muscles so that they get weak with repeated motion or repeated activities. And that is thought to arise from antibodies that are produced by the thymus gland, which interfere with or block transmission of those nerve impulses, leading to the symptoms of myasthenia gravis. One of the treatments that has been there is surgical removal of the thymus gland, and that's been around for 40 or 50 years. And it was first noted by surgeons a long time ago that if you took the thymus gland out, in lots of patients, the myasthenia gravis will completely resolve and get better. Not in everybody, but that's sort of what happens. So in patients with myasthenia gravis who have their thymus removed, I generally tell patients that about a third of people who have their thymus gland removed will be medication-free, and their myasthenia gravis will be well controlled. About a third of people will be on dramatically less medication, but still need some maintenance medication for their myasthenia gravis. About a third of people will see no benefit. Our thoracic group believes that the more thymus gland you take out, the better the potential chance for remission. So when we thought about all these issues and having done all these different procedures, we felt the robotic procedure still offered us the best option and the best potential outcome for patients to remove as much thymus as possible. And so that's why we sort of have settled on robotic resection as our treatment of choice for myasthenia gravis in patients who need their thymus gland removed.
Okay, systemic lupus erythematosus is a severe autoimmune disorder. It's characterized by an inflammation of the skin, the joints, the nervous system, and kidneys, the lungs, as well as other organs. There's often a butterfly rash across the face that gives a wolf-like appearance, hence the lupus in the name systemic lupus. Other rashes can appear on other exposed skin areas. It can develop slowly over years, or it can be an acute onset with fever, joint pain, and fatigue. It occurs most often in women in their 30s and 40s. The cause isn't known for certain, but there seems to be a genetic predisposition. It is an autoimmune disorder, so the offending agent here is an antibody directed against your own tissues. Precipitating events may include stress, pregnancy, overexposure to UV light, and or immunization. So let's take a listen to systemic lupus.
Welcome back to Sansamed. In the following video we're going to talk about systemic lupus erythematosus. So let's just divide first the words and then describe it. Systemic refers to that it will affect your whole body. Lupus will refer to that you will get a wolf-like face. You will not become a werewolf, but you might get some abnormal appearances. And erythematosus because it will affect your blood and its vessels. SLE is an autoimmune disease. You will see it mainly in female African Americans and Hispanics in their reproductive years. So why is it females mainly? It's actually a 9-to-1 ratio between males and females. You will see it mainly in females because females are able to be pregnant. And what's the correlation? Because they are able to get pregnant, their immune is usually downregulated at the time of their menstruation and their pregnancy, and therefore it's easier for an autoimmune disease in general to affect a human. What is important to know about SLE, its signs and symptoms, is essentially the site with high blood flow are the main targets. So you will see how will it affect the brain, the kidneys, the skin, and many other organs. But practically it can actually affect any organ. As many other autoimmune diseases, there are always a target antigen. In SLE, the target antigen is the nucleus, and therefore there is a production of antinuclear antibodies. But this is not specific because ANA are seen in many different autoimmune diseases, and therefore we cannot assume if somebody has a positivity in ANA in their lab work that they have SLE. What we need to look after are the special components of the nucleus that is quite specific to SLE. The one that has the highest specificity is the double-stranded DNA. The normal nuclear DNA is the major target, and it's the most specific one. But it can also be against histones, RNA, Smith gene that is a part of the ribonucleoprotein family. It can even affect your phospholipid membrane and other specific components such as cardiolipin that is found in the mitochondrial membrane, or even the blood components. We'll discuss all of them briefly in a short while. It has its association with both type 2 and type 3 hypersensitivity, and as we describe the signs and symptoms, we will see how they are correlated. What you need to mainly focus on is that it's mainly a type 3 hypersensitivity due to its immune complex formation, the antigen and antibody in the circulation. It has shown some association with some complement factor deficiency, especially C2 and C4. So what can be causes of SLE? There isn't a single specific cause, but there are multiple factors that will be involved. It can be environmental. Environmentally, this can be due to high level of sun exposure. That would explain a little bit why it's more frequent in African Americans and Hispanics. But it can also be due to exogenous pathogens such as certain bacteria and viruses. But it can also be some genetic factors. The one that they usually associate it with is some subtypes of major histocompatibility complexes, class 2, specifically MHC, DQ, and DR. There are even occasions where you can get SLE by some drugs you take. If you have some moderate hypertension, the doctor might prescribe to you a drug called hydrolysin. This drug can work as a hapten. Hapten is essentially a non-working molecule that can bind to a tissue and induce inflammatory reactions. These reactions will give similar signs and symptoms as SLE. That's why the drug hydrolysin can induce SLE or SLE-like symptoms. Other drugs that can do the same is procainamide, which is an antiarrhythmic drug, or even isoniazid, which is an anti-tuberculosis drug. Clinically, what would we see on people that have SLE? We would see something called flares and remission. Flares refers to periods of illness, and remission will be recovery or rebuilding. So this is not always a constant process. This will have its ups and downs. So let's start talking about its signs and symptoms. But one of the major rules that we have to always think about is, as it's a part of type 3 hypersensitivity and its immune complex formation, it usually affects your vessels. As it affects your blood vessels, it will induce inflammation, so we will call it vasculitis. And in the inflammation, there might be several events of thrombosis, which would cause ischemia. So one of the major keywords in SLE will be ischemia, and we will see why. So let's start with the signs, symptoms, and criteria. One thing you might see is a discoid rash. Due to decreased blood flow to your skin, there might be a formation of some skin patches because the skin doesn't have its nutrients, and therefore the skin might pale off a little bit and form a discoid shape, and eventually this can even lead to scar formations. This is usually seen in head areas, in the forehead for instance. Also, due to ischemia to your mucus or even skin, cells will not get their nutrients. These will start to die out, and this will lead to ulcer formations, and usual sites of this are in the mouth area, so you will have some oral ulcers. You can also see photosensitivity, essentially that you're sensitive to light, and this brings us back to one of the environmental factors that can induce SLE. So you will start to get more skin patches and different ulcers and scars, usually on the face. SLE can also induce arthritis. Arthritis is essentially joint inflammation. This can affect any joint, but it's usually more specific to hands and wrists. But although there is excessive inflammation in your joints, this usually does not cause cartilage destruction, so the problems of arthritis will not be that severe if you would compare it to another autoimmune disease such as rheumatoid arthritis, in which the cartilage would be damaged and cause permanent damages. One of the things you usually associate with SLE is malar rashes. Malar refers to butterfly shape, and this is usually seen on cheeks and nose. And the cause of this is essentially the same as discoid rashes, due to decreased blood flow, and also due to the fact that the immune complexes can sometimes deposit between your skin layers, between your epidermis and dermis, and cause blister formations on the face. The immune markers that we usually see are anti-histone antibodies, anti-double-stranded DNA, anti-Smith, antiphospholipid membrane, cardiolipin, and blood components. The ones that you should remember mainly is the anti-double-stranded DNA, because this one is the most specific when you refer to SLE. But if the SLE would be drug-induced, such as you remember, hydralazine, procainamide, and isoniazid, in this case, the usual antigen is the histone. So the antibodies are mainly focused on histone. As you remember from basic physiology, your brain and head requires a lot of blood. So, of course, one of the major affected areas is your brain. So, as there will be decreased blood flow to your brain, this can cause ischemia. There are many neurological problems that can be caused by this ischemia. The most commonly seen in SLE is headache, but it can also cause other problems such as psychosis, anxiety, depression, and many more. As SLE constantly causes inflammation, one of the things you will see in any inflammation essentially is an elevation of erythrocyte sedimentation rate, abbreviated ESR. This is essentially the sedimentation of your red blood cells in 1 hour. As you remember, your kidneys gets 20 to 25% of your total cardiac output, and when you have kidney diseases in connection with SLE, we prefer to call them lupus nephritis. Lupus nephritis can cause many different conditions. This is a very big topic, but we'll just briefly cover that. There are 3 types of processes that are involved: diffuse, focal, and membranous lesions. In this video, we'll just mention that what will happen clinically. Clinically, you will see painless proteinuria and hematuria. So you will see a certain amount of protein and blood in your urine. But as this causes many other different kidney problems, you will see other conditions such as glomerulosclerosis, stiffening of your glomerular membranes, and it can lead to other diseases such as nephrotic syndrome. And you will also, of course, see, since this is a kidney-related problem, you will most likely see hypertension. All of this can eventually lead to renal failure. As you remember, what you will mainly see in SLE is anti-nuclear antibodies, and if you do a test about it, you will see positive values of anti-nuclear antibodies. SLE can also go to your serous membranes. And which are your serous membranes? The easiest way to remember it is the triple P: your peritoneum, your pericardium, and your pleura. And we'll take an example of pericarditis. You can assume that if the pericardium is inflamed as it surrounds the heart, it will affect your normal heart contraction, because it will now compress your heart. When it affects the pleura, it can cause pleural effusion. When it affects your peritoneum, it can cause abdominal pain. SLE can essentially decrease all of your blood cells. When it decreases your red blood cells, we call it anemia. This anemia is also one type of a group of anemias called autoimmune hemolytic anemias. This will fall under our type 2 hypersensitivity in the first subsection, which is opsonization by cellular depletion. Here you will see that the antibodies will attach themselves to your red blood cells, and when your red blood cells will pass your spleen, they will get stuck in the bile rod cords, and then your splenic macrophages will catch them and digest them. So this will cause a decrease in red blood cell number. And in anemias, you will see different signs such as weakness and paleness. If there is a decreasement of your white blood cells, we call it leukopenia. And you can assume if you have a decreased amount of white blood cells, you're gonna be more prone to infections. It can even affect your platelets. The autoantibodies can come and bind to your platelets, and they will get stuck in the bile rod cords of the spleen and eventually causing the macrophages to digest them. This is seen in a condition called immune thrombocytopenic purpura. And here you will see other signs and symptoms such as nose bleeding, called epistaxis, and prolonged menstruational bleeding, and also an increase in duration of the bleeding, and this is a condition we call menorrhage. So how can we remember all of these signs and symptoms? We can make a simple mnemonic, and the simplest that we have found is dopamine rash. This will cover most of the diagnostic features that you will see in SLE. We can also see sometimes a condition called Liebman-Sachs endocarditis. This is essentially that the autoimmunity will affect your bicuspid and tricuspid valves, and this will cause vegetations. In this picture we see a summary of everything we spoke. What are the causes of death and treatments in SLE? As you remember, by its hematological problems, decreased level of white blood cells increases the chances of infections. So if it increases the chances of infections, it will increase mainly the infections that you would normally not get when you're healthy. And these are the types of infections we collectively call opportunistic infections. The similar types of infections are also seen in AIDS patients. So what can be an example of these opportunistic infections? It can be angio-invasive aspergillosis. Another cause of death is end-stage renal disease. So this is another name for renal failure. And there are many conditions in renal failure that can cause death. Another way of death is by pulmonary hemorrhage. So why is that? Sometimes the antibodies can bind to loads of your pulmonary alveoli. If this occurs aggressively in a short period of time, so essentially acutely, it can cause pulmonary hemorrhage. If this problem would occur for a long time, This can eventually lead to pulmonary fibrosis. And the problem with this is that since your right ventricle supplies the lung, the right ventricle now needs to work a lot harder, and as a result of this, it will enlarge and eventually fail. So this is a condition called cor pulmonale. In SLE, you can also get certain lymphomas, such as non-Hodgkin. Cerebral infarct can be due to multiple thrombosis that you might get in your cerebral vessels. You can also get thrombosis in your deep veins, usually in the lower limb, and we usually abbreviate it DVT, deep venous thrombosis. And this can result eventually in pulmonary embolism, which will cause pulmonary problems. So what are the treatments for SLE? We can use corticosteroids. And the reason for this is essentially by using different types of steroids, by their anti-inflammatory properties, they will decrease the formation of antibodies, which are the major factors that play a role in SLE. We can also give people immunoglobulin therapy. And by this we mean that if you would give loads of immunoglobulins to the SLE patient, their splenic macrophages has a receptor called FC receptor. They would get flooded. So they are now busy. Since they are busy now, they cannot digest your own blood cells, and that will help with leukopenia, anemia, and thrombocytopenia. These are usually collectively called pancytopenia. Another way of treatment is splenectomy, essentially removing your spleen, because spleen is the site of the hematological problems. And of course, if you can use corticosteroids, you can also use immunosuppressive drugs. So by depressing the immunity, you will have less antibodies. But this can also be a cause of death, because if you depress the immunity even further, you can increase the chances of opportunistic infections. So what is the final outcome of all of this? SLE, of course, it can be fatal. But it has actually very good prognosis, because this is usually seen in its early stages, and therefore it's highly treatable. An example of this is the 20-year survival rate is usually more than 75%. And hopefully now you know more about SLE. Thank you.
Okay, as I'm sure you're aware, aging does not improve the function of the musculoskeletal system. Osteopenia often becomes evident as we age. After 30, osteoblasts are less active than osteoclasts, and after 40, women lose 8% of their bone mass per decade, while men lose 3%. The difference, again, testosterone. Brittle bones fracture and heal slowly due to a decrease in protein synthesis, and there's also associated joint disorders. Synovial fluid becomes less abundant, and articular cartilage begins to thin, and this results in friction and pain when you walk and move. Osteoarthritis is a common cause of physical disability, and breathing is often difficult due to sternocostal joint calcification. Basically, the cartilage becomes converted into hardened bone, and that reduces mobility in those amphiarthrotic joints. Herniated discs are less common because they are more fibrous and stronger with a smaller nucleus pulposus. This is one of the few benefits of aging here, along with supposedly an increased intelligence quotient, is this exact phenomena, right? There's fewer slip discs as you age. You also see muscular atrophy. That's basically loss of muscle mass and function with replacement of lean body mass with fat. By age 80, we have half the strength and endurance due to muscle atrophy and a loss of fast twitch fibers with severe atrophy. The reasons for the loss of strength is that old fibers have fewer myofibrils, smaller mitochondria, fewer enzymes, less glycogen and myoglobin, so their function is diminished. Motor neurons in the spinal cord exhibit a less efficient synaptic transmission of acetylcholine, and sympathetic nervous system becomes less efficient, resulting in less efficient blood flow to the muscles, and this can cause early onset fatigue. Okay, that brings us to the end of this chapter. Be sure and review this material as it will be covered on the exam, and I'll see everyone in class.